Hi, this is Jeffrey. I'll be talking about my topic is health administration, and I'll be talking about three things, which are the disease management, delivery of care, and health coverage in three countries, which is the US, the UK, and Australia. So, disease management is the most common chronic disease worldwide. Examples are heart disease, stroke, asthma, and some of the risk factors include unhealthy diet, physical inactivity, tobacco use, and excess alcohol. This is according to the CDC. So let's talk about the US. The word disease management was introduced in the 1990s, and the goal was to improve quality in care and reduce costs for chronic disease. Now, the large consumer of the total expense is a large it's a large consumer of the total expense of healthcare in the US. As you can see, 90% of, which is a high budget with 3.8 trillion, is actually spent on uh, chronic conditions and also mental health conditions. Just a brief history is that, over the century, the states, was looking for ways to control the growth of healthcare costs, and rather instead of relying on a government system, which you will see in other areas, the the UK and Australia, they chose the private marketplace. And what happened is that, so you had large employers, like hospitals or insurance companies. You had the federal government and state governments. They all chose, like health maintenance organizations to run, uh, you know, disease management in the U.S. Now, many of the programs are overseen by commercial firms, and what they do is, especially in a developed country, um, you have, uh, you have these firms that buy or sell their programs to, large employers, hospitals, and healthcare management organizations, which are HMOs. Now, what are examples of these companies? Now, some of them are management companies, and some of them are also pharmaceutical firms, um, and many are not pharmaceutical firms. So, for example, you have the Cardiac Solutions, and as the word says, it talks about it deals with congestive heart failure, any problems with heart problems, and you have Merck, Medco. There are many of them, but I'm just giving you two examples, and this is more of a pharmaceutical company. And what they do is that, for example, if you have let's talk about Cardiac Solutions. What they'll do, they'll have contracts with large HMOs, like for example Humana and United Care, and patients who have any problems with heart problems, let's say a myocardial infarction or heart attack, they'll enroll in this company's programs, and then they'll offer these programs will then sort of connect a patient with a disease manager who will arrange for a patient to receive help, things like to quit smoking, or help you reduce your cholesterol levels and managing stress and that kind of thing. So that's how they work. It's just a contractual agreement between an employer and or an organization. So other management services, you have HMOs, right? You have medical groups, you have hospitals as well. Some hospitals have internal programs that, for example, Kaiser or Lovelace Clinic in Mexico. And this is good. This is good because you kind of eliminate the middleman. Now, what's the objective? Now, when a management enters a contract with a client, the hope is I'm gonna save you money, right? I'm gonna cut down costs and everything. So you enter into this agreement, and what's happened is that then what happens is the firm then will then provide services and sell their services by convincing the client that it will reduce costs. Like I said, it is a contractual agreement. Now, do they really work? So, I'm giving you I'm providing two examples here. Glaxo Wellcome Asthma have reported that they reduced 70, they were able to reduce hospital stay by 78%. You have the Diabetes Center who says they were able to reduce healthcare costs by 26%. And the way they do that is that they reduce the number of days a patient has spent in the hospital or in the ER. Now, are these savings real? Over the years, what's happened is that those who are really enthusiastic about, uh, for HMOs um, to, be in contract with these companies, now they're starting to see, the savings are not really happening, especially in the HMO world, right? The savings are kind of weak. They're collecting like 1% profit, that kind of thing, and they're seeing employers expenses go up. And what's happening is here is that a portion of the cost saving from the HMOs is a result of them handpicking healthier, low cost um, patients so that they could see a profit, right? And these programs are skimming off the top so that they can report these lower healthcare costs. But what's happening is that some of them are actually withdrawing from less profitable markets. So if they think that congestive heart failure there's no money in it, so I will not invest in this. And what happens is that you're leaving people behind, and when you're leaving behind, it's still going to cost more money to actually get them on the right, on the healthy side, or treat them. You have government intervention like the CDC. There's programs that have been set up, and there's a budget. And what they do, they find people, they find populations, they educate them, they tell them about intervention programs that will help them as well. And this is another way government gets involved with. This is a way government gets involved with disease management. Now let's talk about the disease management in the UK. Okay. So in England, the majority of care of chronic conditions is funded by the National Health Service, and what it does, it provides care and funds for mostly all chronic conditions. Um, the NHS was set up in 1948, and actually the responsibility of chronic conditions is by these PCTs, primary care trusts, which are now called um, uh, they've been replaced by clinical commissions groups, and these are just locally geographical based organizations. It's like a bunch of GPs that get together. These are general practitioners that get together and share information, and that is good for the patient as well. They are responsible for 80% of the NHS budget expenditure, right? These PCTs, 80% of the NHS budget. You can see how expensive it is treating or managing these chronic conditions, which is about $58 billion. And then now the increasing budget is good, and they actually devolving more of the budget in these PCTs and CCGs, so that there's primary care practices are being empowered to pay more attention to preventive care, which is good. Then you kind of reduce and minimize patients coming and overwhelming the healthcare system. Okay, and they've been policies have been implemented focused on improving care with patients with chronic disease, and these launched in the 1990s. For example, you have these national service frameworks, and what they do is that they set standards for care for common conditions. Initially, they were actually set up for just one type of, let's say, conjecture. They were just set up for one type of chronic condition, for example, just dealing with diabetes. But what's happened over the years, there's been an increased need for integration of services, and what this has happened is that it's kind of triggered an innovative initiatives that have brought a collaboration between the healthcare providers and organizations, and with that. There's a need for, to integrate the services for people who have multiple complex problems, and actually, as a matter of fact, some of these models were, kind of mirrored, adopted from U.S. models. For example, the chronic care model and the risk pyramid model. I'll talk more about that in the next slide, hopefully. No, but basically what the risk pyramid model is it identifies 3 tiers of innovation, which is like case management, disease management, and self-care. And what it does, it targets patients with high, medium, or low risk of clinical deterioration, and then they assign or they assign the right amount of care to the patient, depending on where they fall on the pyramid. The other thing the UK has done is, which is really innovative, is a nurse-led case management, and these are nurse-led care approaches in the primary care, primary care, and these are experienced nurses, and what they do is that they are senior or advanced practice nurses who will help patients with things like developing plans, right? Education, or get in touch with your GP, or using clinical, care pathways and clinical guidelines, or using data to stratify which of the patients is at risk for returning to the hospital, and how do you avoid that? So let's talk about Australia. Okay, disease management in Australia. Now, Australia is interesting because they have an amazing, or this is my personal opinion, they have one of the best, including the UK, one of the best insurance, sort of a public insurance, health insurance coverage. And as you can see, in 2011, the chronic disease was the leading cause of death and disability, and this, according to the report, and actually, according to the GP's report, it was the most common, the GP's report had the most common chronic diseases were hypertension, diabetes, and depression. As you can see from the graph, how these deaths, which is the leading death, which you see the coronary heart disease, but you can see over the years there's been a decrease because of the healthcare system. Now, what is the cost? You could see it costs about $27 billion. That's a lot of money, especially when it comes to disease management. And what does it do? So what these do is that they take care of hospital admissions, out of hospital services, medication, and dental services. And by the way, just to let you know that this is all paid for by the government. This is taken care of by the government. As you can see, the US, you had kind of a decentralized system, but here you're more of a regulated, including the UK, you're more of a regulated system that's controlled by one entity, which is the government. So you can see how this is more organized, streamlined, and more, controlled. Now, how does Australia manage disease? They have policies, right, through a policy work. So, for example, they have the National Strategic Framework for Chronic Disease, which manages and treats chronic diseases, and of course supports preventative care. They have programs, and some of the programs include, Medicare benefits schedule, which helps treat and manage chronic diseases. And this is, you can see, the MBS is part of the Medicare benefits. The Medicaid, actually, their insurance, public insurance is called single payer public insurance is actually called Medicare, and they take care of everything, including, the PBS, the pharmaceutical benefit schedule. They take care of all the prescription drugs as well. So patients actually don't come out of pocket, but if they did, it's really subsidized and manageable. They have consultation services. They invest in research, and of course here come the nurses. The nurses are in general practice settings as well. And just again, this is mostly run and regulated by the government. In terms of ranking, so I want to rank right now in terms of what we just talked about, which is disease management. I would rank UK number 1, Australia number 2, and the US third. And my reasoning for that is, if you look at this graph right here, which is comparisons of chronic conditions, the UK has got the lowest, followed by the Australia, and look at the US. Right, it's above the 11 countries average. If you look at also the comparison of life expectancy, you see the US, you can see Australia's got the best, it's 82.6, followed by 81.3 by the UK, and the US again is last. And of course, it all comes down to access, the control and regulating of disease management, funding as well. As you can see in the UK, it's more of a disorganized system. There's a lot of players and stakeholders involved, as opposed to other two, the UK and Australia, where you have, the government is regulating this whole process. With the US is probably, you talk about efficiency, it's not as efficient. So I want to talk about delivery of care now. We'll begin with the US. The US delivery of care. Let me start with the graphs over here. As we talked about, the US delivery of care is complex and gigantic because, it's the only organization that actually the US is the only one of the industrialized countries that does not have a purely government-run healthcare system, right? I mean, yeah, you do have Medicare, which is partially government-run for a particular population, but it does not cover everybody. All right. So, as I said, in contrast to the United States, it's most developed countries have healthcare insurance, and they're run by the government and financed through the general taxes. And the US doesn't have that. So, as you can see, that when it comes to delivery of care, in the US, look at this. I mean, it's the largest employer. I thought retail would have been number 1, but I was really surprised to find out it was healthcare, right? And how care is delivered through, predominantly, you have private insurance. So these are insurance companies and plans. You have Blue Cross, Blue Shield. Those are kind of plans. Then you have managed care organizations, which are your HMOs and PPOs. And then, of course, you have the government, sort of federal, state-run, federal, which is Medicare, joint federal and state, which is Medicaid. As I said, Private insurance is the predominant source of health insurance in the U.S. And the private healthcare insurance market, includes, as I'm going to talk about, includes grouped care and non-grouped care, but we'll talk about that later. And then in terms of delivery of care as well, I just talk about this here, is that it ranges from, there's a whole team that's involved in this, which ranges from you know research all the way to providers, insurers, medical assistants, lab technicians. So all these individuals are and organizations and individuals are involved in delivery of care. So we'll talk about managed care system. It's the most dominant delivery of care in the U.S. and is available to most Americans. And you'll have the employer or the government is the one who will be funding or the primary financier. Now, instead of getting insurance from like a traditional insurance company, the government or the employer will then get in contract. I was talking about a contract with the HMO or PPO, and in this case the managed care organization will function like an insurance company. Then as members enroll in, they'll have a health plan, and of course they'll be covered with their families. And you'll have primary care providers or general practitioners who typically manage routine services, and also they'll be able to refer to specialists, higher level specialists, which is if they cannot handle a particular problem. And also the choice of major service providers, sometimes is limited, right? Or it depends on what kind of insurance you have. So you might not have access to, you might want to go to a particular doctor, and if you have an HMO and they're not part of that contract, they will not go. You won't be able to go there, or a specific hospital. And that's the thing about the U.S. healthcare system. There's limitations to what kind of insurance, depending on the insurance that you have. So these are kind of the avenues of delivery of care. You have primary care, which roughly makes about 1/3 of all professional active doctors. Most of them are primary care physicians, and they are specialists, and they encompass specialists in family medicine, general medicine. You have art care specialist care, and these are both private and practices and in hospitals. One thing I didn't mention was also you have administrative administrative mechanisms that deliver care as well, and these are your co-payments and providers as well, which are billed to providers. Of course, you have hospitals, and one statistic I wanted to provide was like 57% of about 5,200 short-term acute care are non-profit, and you can see most, and 25% are for profit, and most of them accept Medicare and Medicaid. And for mental health, this is mostly private as opposed to other countries. This could be non-profit or profit. And in delivery of care, you have the military as well, and this is sort of administered or covered by the Veterans Administration, the VA, and you have TRICARE, which allows service personnel and their families to have private care through the VA system, which is kind of a private insurance as well. Then you have the vulnerable populations. You have safety net providers, and these are people who live geographically or in economically disadvantaged communities, and they receive the safety net providers, and which is good because then you have access to, or you may have access to physician offices, hospital outpatient emergency departments, health centers, and you can even get extension of a service and get language translation, transportation, and everything else. That's really good. And these are mostly government run. And the other one that's government run, we all know, are Medicare and Medicaid. And with Medicare, you have plans A, B, and C, and D. And just quickly, short, let me just talk about Plan A will cover, Medicare, of course, is a fee-for-service program, and Plan A will cover hospital insurance. Plan B will cover medical insurance. Part C will then, with Part C, you have an opportunity to go with an HMO or a PPO, if they can provide you Medicaid kind of services, but, with savings. And then Part D will then is a voluntary outpatient prescription drug coverage. And then you have CHIP as well, which is in children's health insurance for families who cannot qualify for Medicaid or cannot qualify for Medicaid and cannot afford Medicaid. So the in between there. I was talking about the U.S. delivery is it's lack of centralization, so you'll have miscommunication. These are all the agencies that are involved, all right, as opposed to having one government run or one entity run, regulated by the government. You have so many cooks in the kitchen, so there could be miscommunication and also inefficiencies. UK delivery of care, of course, is run by the National Health Service. All residents are automatically enrolled in this program. It covers some of the things it covers. This is really amazing. Preventative services, maternity care, inpatient and outpatient hospitals, some eye care. You have long-term care, palliative care, mental health care. So the list goes on, and this is all free to all the residents. Even if you're visiting, you could get free service in the emergency department. All right, you could get care. And what it does is that it oversees, which is part of the NHS, oversees these clinical commissioning groups I was talking about, which govern and pay for care delivery at the local level, and approximately about 10% carry voluntary insurance, which is to gain more rapid access to elective care, things like fertility treatment, bariatric surgery. You want quick access, and then the first point of contact, of course, are the GPs when it comes to the NHS, and GPs play a huge role as gatekeepers to the hospitals and also secondary and tertiary care. Some of the GPs actually are registered. Most of them are, if you look at 60% are private contractors, and then you have locum GPs. And a locum is basically replacement of your GP. If they're not there, they will come in like a per diem and offer services. In the outpatient, make sure I'm in the right place. Sorry. UK delivery of care, correct. In the outpatient specialist care, delivery of care, you have nearly all the specialists are salaried employees of the NHS. Patients are able to choose which hospital they visit, and most outpatient consultants are carried out in hospitals, but you have a small portion that take place in the general practices. And then after hours, you have, since 2014, that has changed. GPs are no longer required to provide after-hour care. However, they have to ensure that there's adequate arrangements. And in practice, this really means that the CCGs contract with private companies and GP cooperatives. So these are kind of private companies that will provide aftercare, but they contract with the CCGs. And then but if you have patients that are serious emergencies, they could go to the emergency department. And of course, delivery of care, you have hospitals. Some are publicly owned, and some are privately owned, but most in the UK are publicly owned. Um, they all contract with local CCGs to provide services, and there's about in England there's about 515 private hospitals offering healthcare services in the UK, and there's a mixture of non-profit and for-profit, and of course private hospitals they offer all kinds of services, fast access like I was talking about. You don't have sometimes you don't have long waiting lines. You could have bariatric surgery and fertility treatment without waiting, and but they generally do not have emergency departments. With mental health, this is fully covered by the mental health is fully covered by the NHS. GPs will handle less serious illnesses of mental health like anxiety and depression, but anything else that's advanced will be taken to specialists. You also have the private sector that also deals with mental health care. You have long-term care, and the NHS pays for all long-term care for people with needs arising from illness, disability, or accident. One disadvantage about the UK is that sometimes some drugs will not be available. Technology is not as prevalent like in the US, and sometimes there's overcrowding. Let's talk about delivery care in Australia. As I was talking about, Australia's got an amazing universal public health insurance program. It is called Medicare, and it is regionally administered and is financed through general tax revenue and the government levy. Enrollment is automatic for citizens. If you're not a citizen, you don't get it, sorry. And they receive, if you're a citizen, you receive public hospital, you receive free, this is talking about free public hospital care and a substantial coverage of your physician services, pharmaceuticals and certain services. Approximately 50% of the population are enrolled in a private supplementary insurance. The government actually encourages citizens to enroll in it, and it does that by providing rebates on premiums for if you go to a private care. But also there's a government levy as well for people who make a certain amount of money. If you don't have private insurance, you will get a government levy. And I know in the US that is infringing on rights, and there's a lot of debate on mandating people to have insurance. But that's another debate as well. And then you have primary care, which is provided by GPs and practitioners who are registered generalists and specialists. The GPs are typically self-employed, and a GP is not required, especially for patients can choose their own GPs and their primary care as well. This is all paid for. This is all free. And as I said, GPs operate as gatekeepers for referral services specialists. And the government also encourages multidisciplinary care coordination, by funding GP clinics, and these are called super clinics. They fund this fully, and through they establish these patient health networks. And then, so in the outpatient world as well, you have outpatient specialist care. With these, they deliver outpatient care in the private practice or in public hospitals, and patients are able to choose the specialist they want, but they must be this is key, they must be referred by a GP to receive the Medicare benefits schedule subsidies. They must be referred. Specialists are paid on fee for service, but also in sort of a incentive program if your patient outcomes are positive. After hours cares, GPs are required to ensure they're not supposed to, they don't have to deliver care, but they have to ensure that there's after care availability for patients. they have to know that they have to make sure that there's processes in place for patients to obtain information. But also there's after hours walk-in clinics, and there's free access to emergency departments. Some patients might use the emergency departments. And also I was talking about these primary health clinics that support after hour services, and there's a hotline as well to call. You have hospitals, you have public hospitals, and you have private hospitals, and over the years in Australia, hospitals have increased, and this is probably all over the world because we're living longer, we're getting more sicker as well. Public hospitals receive a majority of the funding, which is 92% from the federal government and state governments, and the remainder comes from the from private patients and the insurers. And most of the public hospital funding goes towards the salaries of the physicians. With mental health care, this is a responsibility shared by federal government, the state government, and state governments. In Australia, they have 3-tier governments. You have the federal, state, and then local. So this is what I mean by state governments. And it's also provided, mental health care is provided in the GP setting and specialist care, and you have community-based care and hospitals, which could be inpatient or outpatients. You have residential care. So you have all these and then you have non-profit organizations that deliver this type of care. You have long-term care, which is fully funded by the government. Now, in terms of ranking, I'll rank Australia number 1 because of they have Australia number 1, UK number 2, and US number 3. So unfortunately, we're number 3 again. So, and this is the reason why. If you look at the physician visits, you could see that on average, physician visits, Australia is way above the average line, which means that access is fully funded. So people go to the doctors because they don't have to worry about getting broke or having to sell their houses or themselves to cover their costs. The UK is not represented, but I believe it's in between. The US is low. People don't go because I don't have insurance, I can't pay the deductible, the copay, so I'd rather stay in pain. Or that story of that lady in New York who was crushed by, I think it was Boston, crushed by a train, and you see the bones sticking out, and people are going to call the ambulance. Just say no. Do you know how much an ambulance costs? That's really, really sad. Anyway, sorry, I digress. So then you have physicians practicing. You have more physicians in Australia as well. Then you have the UK. US is below average. Look at the average length of stay when it comes to delivery of care. This shows a sign of delivery of care. Australia is 4.2, way below the average. The US slightly better, and then the UK is below average as well, but it's slightly high. Finally, I'm going to talk about healthcare coverage. As we've been talking about the US, some of the things I'm going to repeat myself. It does not have a universal coverage. It's estimated that in 2019 we had about 323 million individuals, and most of the individuals had private insurance or received health care services under a federal program. It's a mixture of public and private sectors, and it's about 9.2% of the US population was insured in 2019. And then you have it's predominantly, definitely private. Look at these numbers as well of the people that are insured versus this enrollment, and also the percentage enrollment, and also and the population. So you can see the insured. This is 1990 with 90%. Look at the uninsured. That's still high. That's 30 million people that are uninsured. But we'll come back to this later. So you have individuals, those also including those uninsured. You have health insurers, you have the federal and state governments. We spent approximately 3.6 trillion in various types of healthcare consumption. can see. And in terms of, this accounted for about 16.8 of GDP. So you have private health insurance programs, you have the federal program, you have Medicare and Medicaid, and those figures of people insured versus non-insured. So this shows the healthcare coverage. What does the government offer? So you have Medicare, which is a federal health insurance program. It pays for healthcare services for people over 65 years old and some with disabilities. In 2019, about 58 million were enrolled in Medicare, and which accounted for about $799 billion. And most of the spending, of course, was for hospital care, physician, and professional services. You can see this graph shows that. This is all hospital care. The next is physician services, and then it goes on forward. Then you have Medicaid, which is a state administered. It's a min-stated program, which means that you have to meet a particular threshold. It varies from state to state, but it's a joint federal state program and finances the delivery of care and acute medical services to a low-income population. This including children, pregnant women, and those with disabilities and people the age of 65. I was reading somewhere where it said, you really have to be extremely poor to apply for this. So who really is covered? Probably, people are covered, but you have to be really poor. A family in Arkansas is a family of four. This is a husband, wife, and 2 kids that earn $32,000 a year. Cannot qualify for that, for Medicaid. So there's a problem there. U.S. coverage, you have the military health insurance, which is channeled through the VA and TRICARE. We talked about that. Of course, we talk about part of which is kind of a mix, private versus public as well. You have the Affordable Care Act enacted in 2010, which then I think you had 16 more million people come get insured, but it expanded the role of funding and regulating healthcare. And with that, of course, it had components in it, which was, it mandated most people to obtain healthcare insurance or face a penalty, but that was removed. Then anyone who was 26 and younger they would still stay on their parents' or guardians' insurance. You had healthcare markets that were introduced, or exchanges that offered premium subs that people would go onto this market, and like you shop for car insurance, you'd go shop for car insurance, but then for a certain population you'd have government subsidies, and then Medicaid was also expanded. Since we have something like this kind of resembles of what other countries have. I don't know why we can just push through and have more people covered. Anyway. UK coverage. This will go quick because we've talked about this already. It's a national health service established in 1948. It's free public health to all residents. It's a government-run healthcare. It covers things like preventive services. I talked about inpatient, outpatient medical. It talks about dental. It covers palliative care, and it's funded through taxation and free at the point of use. Like I was talking about, 10% have got supplemental care, and this is for quick access, or cases that are not, the services are not available on the in NHS. You have automatic enrollment for non-citizens. You could be treated in the ED for free, and of course the source of income is taxation. But you also have patient charges, co-pays, prescription charging. You have dental charging. You have overseas that come over to visit, and their insurance and private treatment. So there's funding. The UK, the government, what's the government role? So they manage the budget. As you can see, the budget has increased over the years. They oversee the CCGs. I already talked about that, which are in connection with other providers and the hospitals and specialists. They employ the physicians. Most of the GPs and specialists are actually employees of the NHS. They also set the strategic direction of the health information technology. The EU have more control. You could control what the physicians make. I don't know how happy they are, but however, you know, they have a chance to go to private sector as well. So um, uh, an example of the private health insurance. There's examples of private health insurance in the UK. The care benefits, of course, you have reduced wait times, private rooms, you know, better amenities. You have specialist drugs that are not on in the NHS, specialist treatments. You have a choice of an MD. It sounds all good, but for what the NHS is providing, free healthcare, anytime, anywhere. That's a good deal. It's pretty good. Australia, in my opinion, has probably got one of the best in the world. It's a universal public health insurance program, which is called Medicare. As I already talked about this. I talked about how 50% is automatic enrollment, 50% have private insurance. The federal government will provide a rebate if you use private insurance through MBS and on the citizens drugs and prescription drugs. It's 10% of Australia's GDP. About 195 billion was spent in 2019, and I think I'm just repeating myself now, but as you can see, it's government run. The sources of income comes from the general taxes, the patient fees, and the levy that's on taxable income. Now, as I was talking about, that the government really encourages people to enroll in this because, you know, of course it funds all the programs I talked about, but also if you make a certain amount of money, you will incur payment if you don't have private insurance. And that's the expenditure. It's about 60% of it is government funded, and of that, 43% is on the federal level, and 25% is from the states, and the remainder is from non-government sources. And also, how does the government play a role? Uh-oh, this is frozen. Oh no. Sorry, my mouse just froze. Oh no. Can I advance this one? I'm sorry, my mouse just froze. Oh, there we go. The government role how does the government role? So like I was talking about, you have 3 levels of government, which are federal, state, and local. And the federal will provide funding to support the inpatient and outpatient cares and other services, but also mainly through the medical benefits scheme, which is MBS, but also and also for outpatient prescription, you have the pharmaceutical benefits scheme. The state will take care of, they will manage service delivery of public hospitals. They will own and manage service delivery for public hospitals, ambulances, dental care, community health. The local will talk about community service, community health services, and preventative health programs. So for the private insurance, it's readily available and offers coverage for out-of-pocket fees and private providers. You have a choice of providers, as I was talking about with private hospitals services. You have fast access to like non-emergent services, and then you get rebates for selected services. You get help, you get insurance for hospital care, treatment, ambulance services, and also what the government does, I was talking about, it encourages enrollment in the private insurance through tax rebates and an income-based penalty for not having private insurance. So if you're a family that makes over $90,000 above $180,000, then and you don't have private insurance, you will get a fine. So let's talk about ranking finally. Sorry this took so long. So ranking, I'll go Australia when it comes to healthcare coverage. Australia, UK number 2, and US. And the reason for that is because if you look at expenditure, US spends a lot of money per person. Look at that, $10,000. The UK is less, and then next is Australia. Okay, the thing about the UK, yes, it is really lean, but there's also drawbacks with that. Like I was talking about access. Sometimes access is there's long wait lines, or some of the places there's no beds, or some of the GPs are full. There's that disturbance of being so lean and budget constraints. If you look at the healthcare system performance rankings, Australia is number 1 with administrative efficiency and also healthcare outcomes, and that's why I ranked Australia 1, UK. UK is just slightly under Australia. I probably have Australia and UK as number 1 and the US number 3. And the US, as we went through, you could see why I ranked them number 3. Ranked as number 3. My recommendations are, why don't we adopt a mixture of the Australian and UK services? And by that I mean provide universal coverage and access. Australia has a Medicare program which resembles the one of the US. We can just fund through taxes. It's already being done. Expand Medicare or expand Medicaid, or eliminate Medicaid and just have Medicare and just expand that. Of course, you'll have private hospitals, you'll have public hospitals, you could have insurance companies. Yeah, they'll still be around. You're not getting rid of them, because we're a huge population, so you'll need the private sector as well. But expand Medicare. As we spend a lot of money, so look at the UK. They spend way less to cover such a population, and we spend a lot more money. Yes, there's more of us, but a lot more money is going into these black holes that nobody doesn't know where the money is going, and our health outcomes are really bad. So we're spending more, and then we're sicker than the rest of the industrialized world, who are spending less, and they having great patient outcome. So have one system which will coordinate, control, and regulate the healthcare coverage. Every worker should contribute to the Medicare or whatever it will be called, the Medicare system. Provide options for supplemental insurance like and subsidies like Australia does. Eliminate high deductible. This would definitely eliminate high deductibles and out-of-pocket costs, or people getting trapped on the train and saying, "Oh, don't call the ambulance." Of course, this will also standardize basic benefit packages, because in the UK, I think we spend a lot of time with administrative work, filing claims, who gets reimbursed what, how much money is this particular service. If you standardize a process, it's more efficient, right? Then doctors can actually care, or people who are in healthcare can actually spend more time providing care to patients, and also more money, more funding to preventative costs, preventative measures, especially when, as we talked about, 90% of our budget goes to chronic conditions. So we could have more funding, but also we could have more preventative care, and also will empower physician and patient relationships, because in the US, you have these private insurances that kind of come in the middle of patient and physician. Remove the middleman, and we become more efficient. Here's my references, and thank